So, good morning and welcome. I am Sarah Weatherston, she, her pronouns. I'm a white woman with gray and brown hair and glasses, and I am lead staff for the Medicaid Advisory Committee, also called the MAC. And this is the MAC's public meeting for December 2024 to help fulfill its federal and state mandates to advise both the Oregon Health Authority, or OHA, and the Oregon Department of Human Services, or ODHS, on running the Oregon's Medicaid program. And I'm going to share a few logistical announcements before we get started. We'll ask that folks mute themselves if they're not speaking. If anybody is joining by phone, we ask that you mute yourself if you're not speaking, and please avoid putting the meeting on hold. If you have to leave, it's better to hang up and rejoin the meeting. MAC members will ask you to use the raise hand button if you have a comment or question, or put a note in the chat to let us know that you're ready to speak. The Medicaid Advisory Committee has built in time for discussion after each presentation. MAC members will speak first, and when we've exhausted questions from MAC members, if there's any time remaining on the agenda for the item, we'll take general questions. And we also have today 20 minutes for public comment near the end of the meeting. We do have ASL and Spanish language interpretation available for today's meeting. You can pin the ASL interpreter's video by clicking on the More button next to their name. There's also a button for interpretation, which is where you will find the Spanish language interpretation at the bottom of your Zoom screen. So with that, I'm going to hand it off to MAC co-chair Dr. Caroline Barrett to take us through our meeting. Dr. Barrett.
Good morning, everybody. Welcome, committee members and members of the public. We'll start with roll call. So I am here. David Lima. Emma Sando.
Here.
Heather Jeffress.
Present.
Hillary Thompson.
Good morning, I'm here.
Jerry Weeks.
Here.
Kaya Adams. Kelly DeVore. Laura McKean.
Good morning, I'm here.
Good morning. Lisa Pearson.
Here.
Ronnie St. John. Shannon Buck.
Here.
Stacy Shaw.
Present.
Dr. Tony German.
Morning, everybody present.
And it looks like Peter Starkey is out. And I'll circle back. Kaya, are you here? Or David? All right, Sarah, do we have a quorum?
We do have quorum, and I have a message from Kaya Adams that she will be a little late.
Okay, wonderful. Well, good morning, everybody. Okay, thanks for being here today. Committee members, last week you received draft minutes from our most recent regular meeting to review. So please take a moment to review the minutes for any errors or omissions. And feel free to jump in if there are any concerns about the minutes. We'll give you a minute to review. Are there any concerns about the minutes? Oh, and Sarah's noting that Kelly DeVore is here. Great, thank you. And if there are no revisions, I also want to call attention to the consent agenda, which you also received prior to this meeting for review. Do I have a motion to approve the October meeting minutes and to acknowledge our consent agenda?
This is Lisa. I'll move to approve.
Thank you, Lisa. Do I have a second?
This is Heather. I'll move to second.
Thank you, Heather. Are there any objections? Any abstentions? I'm going to abstain since I was not at the last meeting. Okay, the motion carries. So we are going to be moving on to our Medicaid Director, Emma Sando, who will be presenting the initial agency response to the Ombuds report recommendations. Emma, I will pass it off to you.
So much. Hello, my name is Emma Sando. For folks that I have not met yet, my pronouns are she, her, and I am a white woman with brown hair. I'm so happy to be joining you today to discuss our Ombuds report response recommendations, as well as to be part of this group. This is, I believe, my third meeting as a member of the MAC, and I am looking forward to continuing to provide you updates on the goings-on of the Medicaid program, as well as other updates and responses to any questions that folks may have that I can be helpful on as we work together in the MAC. I'm here with a number of my colleagues from the Medicaid team who have helped and led a lot of the work that we are performing in terms of response to the Ombuds report. We appreciate all the work of our Ombuds team and of the MAC for reviewing these recommendations. And I thank you all for giving me a little bit of a preview ahead of our formal review of the Ombuds report a few months ago. So I'm going to dive in here, and we'll have an opportunity for questions at the end, and as well as we can have a number of folks who are on be able to respond to some specifics. If we can't, then we will take them back to make sure that we get you accurate information. Next slide. So one of the recommendations was around enhancing culturally and linguistically specific services, also known as CLAS or CLSS payments. Culturally and linguistically services are health services delivered with design and intention to support minoritized communities. These are communities that have been harmed in the past or present based on the community's race, ethnicity, gender identity, sexual orientation, ability, status, migration history, or other aspects. These providers, programs, and organizations have experienced serving these communities. Starting in February 2023, the Oregon Health Plan began making CLAS payments to qualifying providers for outpatient behavioral health services. Our focus on behavioral health as part of the program is to improve the system overall and to continue recruiting and adding participating providers. One identified area of work in front of us is to address the burdensome and difficult credentialing process that behavioral health workforce providers must navigate before they can become or they can get paid and become qualified providers. Additionally, we do find that there is a significant amount of confusion around payer funding of the new benefit. So effective in the first quarter of 2025, the CLAS payments will be expanded to include doulas, community health workers, resident and residential substance use disorder providers. We're finalizing the administrative rules, updating application forms and guidance documents, and configuring payment systems to account for all of this. In addition, we're interested in expanding this program to further include dental and physical health providers. We see this program as highly aligned with our broader agency goals around ensuring access to care. And we're exploring how to fund expanding it and how the program may need to be different from the current behavioral health program that exists. We're working on funding and we're planning external engagement in the project design before fully developing it. But it's critical that we have input from clinics and communities to inform the program design. We have not set a target effective date yet, as we're still very much in the planning date. But I do want to note that also uh, OHA and Medicaid has hired a chief dental, physical or oral health and dental clinician, and having that our dentist on board is really going to help us through this process. Next slide. Another recommendation was focused on fee-for-service add-on for interpreter time. And we know that the current $60 add-on for fee-for-service interpreter service is insufficient to cover the cost for many providers. And the Ombuds recommendation is to set up additional fees. Providers can bill for longer visits when they require more interpreter time. The the challenge here is that the interpreters are we want to make sure that the interpreters are paid a living wage. And SB 1578 directs OHA to develop an online portal where providers can schedule certified qualified healthcare interpreters. And these interpreters can be paid directly. And OHA will be negotiating healthcare interpreter rates with the Interpreters Union as we get further along in the process. In the interim, we're exploring additional ways to ease the burden on providers. The data suggests that a $60 add-on fee is significantly underutilized. So outreach to providers to help them get reimbursed for some of these costs is one way in which we can ensure that interpreter services are being paid for their time. And so we're crafting communication and outreach efforts around how the $60 add-on fee can be billed in the fee-for-service environment, and looking into whether training is required as well. Next slide. So here's a timeline of the interpreter schedule portal, which I mentioned in the last slide. And we're really at the beginning of planning the process, and this timeline is likely to evolve quite a bit. So I wouldn't write all these specific dates on your calendar. But I would say that generally we are in the process of planning and working through the contract process. But we do know that we have quite a bit of ways to go before we can fully implement all of these requirements, in part because we really want to make sure that what we're producing is something that will be used and works for the community. So this is what this represents. The limiting factor is around contracts, timelines, and procurement processes, as those are things that often take quite a bit of time, and we want to ensure that we are meeting all of those different requirements that have a significant lead time. So there is a contracting requirement through a request for proposal, et cetera, that can take quite a bit of time. And we're looking at ways in which we can ensure that we are being as efficient as possible, but do want to note that some of these things are products of the mechanisms that are required for contracting law and purposes. It's important to note that many of these are occurring at the same time, even though it looks sort of like start and stop. We are particularly, if I draw your attention to assessing the community needs, that really occurs all along the way in every stage of the process, or workforce development is a really ongoing part of the process as well. Next slide. Another major part of the Ombuds report was requiring statewide behavioral health networks. So OHA established directed payments for behavioral health providers to improve access. And there were two types of directed payments. One is the behavioral health providers providing ACT services, supportive employment services, outpatient mental health treatment services, and outpatient SUD treatment services. And then the second was around behavioral health providers offering ACT, supported employment, applied behavioral health analysis, wraparound services, outpatient mental health, substance use disorder services, residential treatment services, and which meet all of those class guidelines. So we built upon the infrastructure made in 2023 and further improved network adequacy standards for our contracts with our coordinated care organizations, and updated some of those network adequacy timelines in terms of the time and distance standards. So ensuring that access to services means that even if you have something in the network, that you can actually get to the provider in an appropriate time or distance, as we know that particularly in rural areas, the access really needs to mean access, because a person might take hours or whatnot to travel to the behavioral health provider, and so updating those contracts are really important. We launched an exceptions process to work with CCOs to address the root cause of some of those gaps in services, and then improve some of our dashboards to look at evaluations of monitoring those access information, because we really want to make sure that access means access. This is all to just ensure that when we're looking at data and whatnot, it's realized access for people, and not just sort of a numbers on a page. So that all of these are working to ensure that we really are getting a better understanding of what it means for the member, and not for checking a box in terms of network adequacy. So we use a secret shopper survey to address the various service needs, as well as validated the data that we were provided by the coordinated care organizations, and developed frameworks. Next slide. So some of the additional work that we will continue to do will be building on those efforts to really ensure that we do have network adequacy, and follow up with the CCOs that are not meeting these expectations. Procurement will also be part of this, to set additional standards and expectations around network adequacy. One thing I'll also mention is that the new managed care rules, which came out this year, focus on ensuring that managed care organizations, or in our case, coordinated care organizations, are achieving network adequacy. So as we work to implement that rule over the next 7 years, we are working towards increasing those requirements and reporting that will be to our federal partners at CMS. And I know that the federal government had quite a number of plans to make that information public and accountable, so that the public is aware of how managed care organizations are performing in this space. Next slide. So the final point was around expanding the ombuds capacity and increasing consumer voice in informing OHA policy and operations. So this is a visual here of the ombudsman's concerns received over the last 3 or 4 years since 2020, and a couple points I want to show here is that we do see a variety of reasons for this for the increase in both all concerns and Medicaid concerns. One is that we have a focus on engagement, and the agency focus on being responsive to concerns, especially those that impact health equity. So the Ombuds program strategic outreach to populations who have faced historical and contemporary health inequities and lack of access to care has been a real big focus of this work in general, and how we center the member voice in all of the work that we do. Um, so we really believe that the Ombuds program has an essential role in the member centered role that we are working to build at OHA, and want to illustrate here that that there is the a need for additional staffing and support for the Ombuds program as we are working to make sure that we are addressing the concerns that we hear, and showing that is an area of strong focus in OHA to achieve our goals of eliminating health inequities by 2030. So next slide. I did see some chats come through, but I hadn't had an opportunity to read them yet. But it sounds like we're very excited to have the dental director in place, and I wanted to see if there were any other comments about this presentation. I
Thank
believe
you so much, Emma. I'm appreciate the very detailed response to what's been going on. It sounds like there is a much more robust response than I think we had previously been aware of. So thank you very much for this. I am curious what components of, I have two questions. What components of the dental physical health are you focusing on expanding for the linguistic cultural expansion? Is that primarily focusing on bilingual providers, or how are you hoping to address that? And then the other question I had is about the network adequacy for behavioral health. Is telehealth being included in network adequacy, or is this, it sounded like you're focusing on ability for in-person access?
But if you want me to weigh in on the class one, I can. I have some
I was
comments
just
there.
about to see if
Yeah,
Nathan was on. If Nathan,
happy
if you wouldn't
to.
mind introducing yourself before.
Yeah, hi, I'm Nathan Roberts, and I am a manager with the Oregon Health Authority in our Medicaid policy team, and I work for Emma, and my team is leading well with many partners, but working on expanding the class. Um, we are still very early in planning and exploring how we might expand to dentists and to physical health providers. One of the things that we have batted around, it's still just a concept and definitely not a set, we're going this direction, would be to only partially expand, maybe only bilingual providers at first. The other components have to do with are the clinics providing services that are culturally specific, right? That are maybe a primary care office wants to really tailor their services for the Russian speaking community or something along those lines, right? In the behavior health model, either bilingual or the culturally specific can qualify, and we can make payments. So ultimately, long term, we want to have equally, be able to recognize all of those. We have batted around the idea of maybe a baby step, or a first step might be just the bilingual. But we have not secured funding for those things, nor have we set our path forward. So we are discussing it, though.
Thank you.
Yeah.
Appreciate hearing what ideas are being floated. That's very helpful. And Emma, are you able to address the question about the telehealth network adequacy?
I believe the answer is yes, that telehealth is included. Exactly how it's included, though, in network adequacy, we'll have to I believe bring that back to you unless I've got somebody that wants to chime in here from the Medicaid team. I don't think I have the
No
uh,
problem. I just know, and Heather, you can probably weigh in on this as more as well, but I work as a primary care physician primarily, and many of my patients prefer in person for services across the board. And while I just want to advocate for including that as a bulk of the network adequacy and the telehealth being part of it, but not fully relying on that. So thank you so much. I see, Heather, that your hand is up.
Yeah, thank you. And I too wanted to say, Director Sando, really, really appreciate your thorough feedback and all the excellent work that you're leading in your division to address these issues. So thank you so much. We're super excited for that. And I had a couple clarifying questions. Maybe one is for Nathan. As a my background is behavioral health. I'm a director for statewide trade association with over 70 agencies, who have over 8 to 10,000 employees, many of which were the first organizations and individual providers employed in those organizations to get the CLSS in behavioral health. Wondering, is there going to be I know there's not too many that are certified. So are you going to utilize them as a focus group to troubleshoot? Because one of the things we did note, the individual provider certification process was excruciatingly rigorous, and there were many employees who reported that even though they were native speakers, had spoke their language at home, they failed the test because I believe it's a very formal test equivalent to state interpreter standards. So I was curious about that to improve access for individuals who are bilingual, if there had been any changes or updates or improvements on that piece, or if you're thinking about doing that in the future. And then also, it seemed like the agency application was much more simple because, of course, agencies who are providing linguistically specific services, that's what they do every day. So it seemed to be more simple and effective, and people really appreciated that approach, and how effective and efficient it was. So that would just be my comment and my question to you on CLSS as you're thinking about expanding. I'm so excited because we, as providers, and many of our employees with lived experience, were just ecstatic that this is such a direct opportunity to impact health equity. So thank you for looking at it, expanding it, and all the work you're doing on the program. It's just really exciting.
Yes, thank you. Also very excited. I think it really aligns with and lets us support amazing work. For the behavioral health side, I don't have any specific details to share about changes that are imminent, but we are in that's the phase that we're in right now, is refining, looking at ways to streamline, looking at places where maybe we got things too stringent or not stringent enough, and making those adjustments. So that's the work that the team is doing on the behavioral health component of this right now.
Yeah, I know our members would be happy to support you in any way to give you feedback on that. And I know they do regularly, for those who are already certified or trying to get certified. My other quick question is, I was curious about a lot of these things around network adequacy really align with the OHA parity report. And I was wondering if you were leveraging those two things to gather data and how they were connected. because it seemed like there was some interesting opportunities there to get similar data points and information to cross-pollinate those two work projects. I don't know. And we didn't really mention parity, but that network adequacy is such a huge component of parity.
One thing that I will flag is that CMS also just put out quite a bit of additional requirements and information around parity, and we are working to examine those, and a lot of work to come in that space more broadly.
Okay, well, thank you so much. Those were my two items.
Thank you, Heather, for bringing up those points. I know I'm definitely passionate about the language certification. Having gone through it myself, it can be quite challenging, and can boggle my mind sometimes that my colleagues who are native speakers, that they've not passed the testing. So I definitely think there are some areas for improvement there. Dr. German.
Yeah, thanks, Caroline. To that point, and I think Heather's point to just a reflections in an organization that has targeted support for the Latino community. We traditionally are a community health center that has had our medical assistants serve as interpreters. But we've had challenges, and I think the call out that how rigorous of the testing to be certified is a really important point. As far as having somebody having a literature degree and being able to pass a test in a context, and I don't think that's really kind of ones, but some of those tests I've taken those, and I've passed some of them, and some of them I haven't passed, and it's curious with those. And I've been serving this community for about 13 years, and a number of my colleagues that are native speakers and for medical assistants and nursing staff are native speakers as well have had struggles with that. The other reflection we give is that some of those roles pay less than an interpreter. And so for somebody to go and do more training or to invest in that, we need to be cautious with regards to what that does for the workforce. It's already hard to recruit in some rural communities. And so if we put the bar too high, the intentions are good to make sure that we're being very thorough and providing adequate services for interpretation and understanding of language. But there is a trade-off with some of those, and I think that that warrants attention, that we don't push people from one area to the next, and the enemy of good is perfect. So just kind of, I think an attention to that would be good. Um, um, Director Sando, I had a question, and this may not be in the right space, just with regard to credentialing, and particularly for our behavioral health colleagues. Could you flesh that out a bit more as far as how that's proceeding and the idea that, and this happens for providers across the board, I know for multi, is that the challenge is that they have to register credentialing with one CCO, but they're served by a couple in the same area. And it serves quite a barrier to care and a delay in care for a number of health systems and clinics. And maybe we could take this offline, but I'd just be curious how we're proceeding with that, trying to simplify that process.
Yeah,
Oh, you got it, Emma.
I can turn it over to you, Nathan, if you'd like. But I will say that we have heard from folks that there are the process is not straightforward and simple, and we recognize that, and that there is some broader work to it. Make sure that it is a process that is requiring what is needed, and not overly burdensome on providers, as we do want to make sure that we do have access to providers in our system, and if that is a barrier to care, that is one thing that we are looking at. However, I will say that many of the rules and requirements are federal mandates on what is required to be a Medicaid provider, and what we and then there are other state level requirements. So determining what is within our ability to be more flexible is versus what is a federal requirement and whatnot that we can't make changes to is a bit of a challenge that we're working to overcome. But I will see if Nathan has any additional things to add or
Yeah,
but I'm
no, I think you said it perfectly, Emma. There's a lot for us to navigate in this space, and so uh, definitely something we're interested in smoothing and making as good as we can. Probably you're going to see things more along the lines of guidance and best practices, and probably I don't anticipate that we will be able to, for example, achieve a standard like one credentialing process that all CCOs and fee-for-service everyone uses. I think that it's more likely that you're going to continue to see what you've described, where it's a little bit different for each CCO. So if one provider is serving members that are in several CCOs and in fee for service, they'll likely still have to go through uh, 3 or 4 right credentialing processes. So our to really keep aligned with all of our requirements that we have to navigate. I just want to give the MAC a heads up. You're probably more likely to see guidance and best practices from us, and maybe not. We'll do it if we can, but maybe not new regulatory requirements.
Well, thank you so much. We are at the little few minutes past the end of our time for this. Heather, I do see your question. If you could maybe forward that to Sarah and Owen. I missed these. There were comments from Shannon and Lisa in the chat. So that we can forward these along to Director Sando and her team. And if Heather, if you want to pass your question to Sarah to forward as well, that would be great. Director Sando, Nathan, thank you so much for your time and expertise this morning. We really appreciate you helping us understand this and understand the work that your team is doing. So we are going to move on to our next item on the agenda, which is the Bridge Program Update. This is being delivered by Tim Sweeney, who's a lead policy analyst at the Oregon Health Plan Bridge Plan at OHA. Tim, are you here to join us?
I am. Can you all hear
Wonderful,
me?
thank you. Yes, I'll pass it off to you.
Great. Well, thank you so much. Happy to be here to provide what I think is a fairly brief update on OHP Bridge, which is a new program implemented in July this year. So I think the next slide has the agenda or what I'll walk through. Just again, a quick reminder of what this program is and who it serves. A brief update on enrollment as of the beginning of December, and then a few slides to talk about next steps and future work and some ongoing outreach and enrollment activities. So first, just a brief reminder of what OHP Bridge is. It is a new program for adults with income above the traditional OHP threshold of 138% of poverty and up to 200% of the federal poverty level. Again, it is only for adults, and that's due to federal rules. So it's 19 to 64-year-old state residents who do not have access to other affordable health insurance coverage. This is the same requirement that exists for folks to get tax credits for marketplace plans. And they have to have an eligible citizenship or immigration status to qualify. It's not identical to the Medicaid citizenship and immigration requirements. It's more consistent with the requirements for individuals to get marketplace tax credits. So for instance, the 5-year residency requirement that exists for many immigrants qualifying for Medicaid does not exist for basic health programs. So it's a slightly a slightly broader eligibility, slightly more flexible requirements there. It is almost the same as OHP Plus. It covers the same CCO delivered benefits, but does not include long-term services and supports, and does not include health-related social needs that are currently getting rolled out as part of the 1115 waiver. But otherwise, the benefits are the same. And much like OHP Plus, it is free coverage for members. There are no premiums, there are no copays or deductibles. So the program broadly, this new program has two. Oh, sorry, we did not get the. I thought we sent over the updated data, so I'll be able to tell you what the enrollment numbers are. So there are two parts of the program. One is OHP Bridge Basic Health Program, which is managed exclusively by CCOs. There is no full fee-for-service or open card option, and there are about 30,600 members in this portion of the program as of December 3rd, as of yesterday. And then OHP Bridge Basic Medicaid is done through a Medicaid waiver, and this enables Oregon to offer American Indian Alaska Native members who in Medicaid are exempt from mandatory managed care enrollment. It enables us to create that same exemption in basic health program. There would be no option if we didn't have this separate aspect of the program. And there are 827 members on this new Medicaid eligibility category, which covers the exact same benefits as the OHP Bridge Basic Health Program. It really is together, these two are components of one program that offers the same services and the same benefits, with the one exception that people who meet the federal requirements for being exempt from mandatory managed care enrollment continue to have that right to opt out of CCO coverage for this program as well. So the next slide talks a little bit about expected enrollment into the program really over the next couple of years. So the program was created July 1st, and right away, some people moved directly from OHP Plus, from a temporary Medicaid expansion that was put in place during the PHE unwinding to keep people enrolled in OHP who were identified during their redetermination as having income between 138 and 200% of poverty, while the state continued to finalize the development of the permanent programs of OHP, Bridge, BHP, and Basic Medicaid. So 22,000 people went through their redetermination process and were found to have income in this range. Instead of booting them off Medicaid, we put them in this temporary Medicaid expansion category so that they could move directly into OHP Bridge on July 1st. Also beginning July 1st, people who didn't have coverage could apply for enrollment into OHP Bridge, and people who were covered in the marketplace in this income range could also move to OHP Bridge by doing one of two things. One would have been updating their marketplace application, changing their address, updating income, doing something in that healthcare.gov portal that sort of like prompts a new look at their eligibility, and would have prompted healthcare.gov to say, oh, now you're eligible for this new program that the state is offering, and it would have sent their information to the state. Or somebody who is enrolled in a marketplace plan could go directly to the one system and apply for coverage, apply for Medicaid and OHP Bridge all at the same time. We have seen steady growth from that initial 22,000 who moved into the program in July, and to the question in the chat about whether we can know who's coming from being uninsured or from the marketplace. We don't have that information. We are trying to figure out how we might be able to get that. Eventually, we might be able to sort of back into something that shows the transfers from healthcare.gov versus people who came in directly to the one system. But the confounding factor there would be somebody from a marketplace plan could have applied directly from the one system instead of getting their account transfer from healthcare.gov, and we would have a hard time being able to differentiate them. But we do expect more enrollment growth over the next couple months, especially as the open enrollment period fully ramps up. I know it started November 1st, but because of the enrollment staggering rules and when somebody comes into OHP Bridge, we think January and February are when we'll see the bulk of the movement from folks from the marketplace. I can pause here for a second. I know I did see the one question. I don't know if other questions have come in before switching gears a little bit. This is sort of like the first half of this is a bit of a program background and reminder. So just want to see if there's any questions before I move on.
So I see Tony's question in the chat of, do we know the breakdown? Are you able from uninsured to BHP and marketplace to BHP?
Yeah, and that's the one I saw and answered. Like
Great. Okay. Just making sure. I thought that's what you said, but wanted to make sure.
Level of,
Thank you.
So it's just essentially like 8,000, and it's hard to break down between those two.
Yeah, we will be able to, and we're trying to better understand. I don't think there's much movement right now from OHP Plus to OHP Bridge because of the 2-year continuous eligibility rules that have gone into place with the waiver. We're kind of still in that time frame for most people. I think when we get to where we have a state-based marketplace platform in a couple of years, it will be much easier for us to sort of look at that data together and see who's moving from the marketplace versus who's coming in from uninsured. But at the moment, I think we'll be able to eventually do some look back and look for account transfers from healthcare.gov, but we just haven't been able to do any of that yet.
Thanks, Tim.
Yeah. So I see another question. Yes. around you, basically how we set the income thresholds and why do we use the federal poverty level instead of some other threshold that might more accurately reflect the amount of income somebody needs to earn their own coverage or something like that. And the simple rule is that's what's federally required. This is a program that is authorized and created in the Affordable Care Act, and the eligibility rules are set by that by federal statute and by federal rule. And so if we want to offer this program, we are confined in that respect in terms of who is eligible for coverage and how we have to evaluate their income. And it's similarly in Medicaid, that is the federal threshold and just how we have to operate these programs. Okay, moving on, I believe. Just a little bit more about OHP Bridge and open enrollment. This program was launched on July 1st, in the middle of a year, in the middle of a plan year, and people in this income range are already covered by marketplace plans. And that really did inform the strategy for communications and outreach to individuals, and really the desire not to disrupt coverage for folks who have marketplace coverage in the middle of a plan year when maybe they don't want that coverage disrupted. So that initial campaign really focused on finding uninsured folks to apply for OHP broadly, and to go through, to work with the sisters and to go through whatever application source is going to get them most quickly to the right place. because of it not aligning with open enrollment, the decision was made to sort of hold off on broad OHP Bridge specific communications, and instead focus on sort of more general outreach to a broader swath of people to just get people to go and apply for coverage. And really, I think the desire to limit disruption, especially for folks who were halfway through a plan year, maybe they've already met their deductible, they've got relationships with providers, and not having unnecessarily folks going through that coverage transition in the middle of a year when maybe they're in the course of treatment or have stuff planned for their year. Onto the next slide. There is more specific outreach happening now, in addition to the broader outreach happening related to open enrollment. There's messaging on the transition page of OregonHealthcare.gov speaking to marketplace referrals and the existence of this new program. We have a partner FAQ and toolkit and outreach materials that we're working with a variety of assisters and other community partners who work with members every year at open enrollment to help them get into the plan they want and into the right coverage. There is digital advertising promoting coverage. Again, still some of that is not program specific. And then there's other broad open enrollment, OHP Bridge messaging through social media and other partner communications. And then one quick side note is beginning November 1st, individuals with DACA status are eligible for marketplace tax credits and basic health program and OHP Bridge. And that is a new rule set forth by the current administration. And so there is also some outreach and messaging related to that to get folks who've previously not been eligible for marketplace tax credits, who are now eligible because of that extension to DACA folks. And then lastly, a little bit about next steps on the next slide. So open enrollment runs through January 15th. And I do see a question in the chat, and I can get to that after just this one last slide. Open enrollment runs through January 15th. The eligibility start date rules of OHP Bridge, somebody who goes through the eligibility process and is determined eligible for OHP Bridge, say on January 12th, right before the end of open enrollment, their coverage will start on February 1st. And if it's after the 15th of January, for instance, their coverage would start on March 1st. So I think that continued open enrollment in December and the first half of January, we expect to see larger enrollment jumps in January, February, and potentially March. Our team is continuing to work with the External Relations Division, communications teams, the marketplace team as well, to ensure that folks are aware of this program and know what to do if they're trying to move from a marketplace plan or to apply from being uninsured. And there will be some additional informational webinars coming in December, again, working with the marketplace team on this one. With that is the end of our slides, and I did see another question, and so I'll pull that up.
Yes, thank you so much. I actually had a similar question as Tony about if there are any initial comments, and I fully acknowledge that there is a lot of we don't know what's going to happen, a lot of speculation at this point, but just wondering if there is any contingency planning of if changes in Medicaid payments, be it in forms of block grants or capitation, would be impacting things like DACA or bridge program existence, expansion. Do we have any knowledge at this point, or are we all in the speculative realm?
I think we're all still in the speculative realm. I mean, certainly as it relates to this DACA rule, there's lots of speculation as to what may or may not happen. I mean, I would refrain from offering my own take because
Of course,
it's just as
totally
knowledgeable
understand.
as anybody else's. But to the other pieces as well, lots of speculation of potential Medicaid changes, potential changes related to marketplace tax credits, the enhanced marketplace tax credits that were initially put in place by ARPA and extended by the Inflation Reduction Act. Those have a significant positive impact on the revenue that we get for our basic health program. And so those need to be extended by the end of 2025. So that would have implications in 2026 and beyond. So I think it's sort of too early for us to have like any solid contingency plans other than trying to just be prepared for a variety of different scenarios and really make sure that we're broadly thinking through response to any federal changes. And to that end, I would just note that there is an advisory committee very similar to the MAC for OHP Bridge. It is called the OHP Bridge Advisory Committee or OBAC. And that will be a space for OHA staff to get guidance from a committee similar to this in terms of how we think about dealing with federal changes, and certainly a space for staff to be able to offer updates about what we're learning when there are specific federal proposals, either at the congressional level or draft rules put forth by the new administration. And certainly we can come back to this venue as well, but just wanted to make sure that folks are aware that there's another venue that is dedicated to this program where we'll also be able to provide that information.
Wonderful. Thank you so much. I think it's just something that is on many of our minds. So I just wanted to acknowledge that. So thank you for addressing that. I see that link about the OBAC has been put in the chat. We have just a few more minutes for comments. Heather, or questions. Heather, I see your hand is up. And I also see a comment in the chat from Shannon saying that, yes, that many of us are assuming that cuts are coming. So yes, big deep breath. Heather.
Yeah, on that line, your team has done such a good job with your communications folks for really bringing communications with consumers and providers up to a whole new level than it was a few years ago. So I want to say kudos to that. And is that going to be, I'm going to guess, and just maybe this helps relieve my anxiety. I'm guessing that communications component is going to be part of coping with any potential changes or alleviating people that nothing has changed yet. Because I know that many of our in my day job, not on the MAC, but at the Oregon Council for Behavioral Health, representing behavioral health agencies that provide substance use and mental health services. Not only are the employees and the healthcare workers in those settings, but also the patients, consumers that we serve are having a lot of anxiety. And it would be great even just to have like, nothing's changing yet. Everything's the same. We're all good. And this is what we'll do if changes happen, kind of communications. I'm just wondering, I'm sure you guys are working on that because you've done such great work with that, but that's kind of my comment and query.
Yeah, super appreciate that. And comments in the chat. I certainly wouldn't want my earlier comment to suggest that this contingency planning is not happening. I just don't know that I could speak to sort of like specifics of it. I think that's happening throughout, at our program. It's, focused greatly, obviously, on OHP Bridge. Certainly all of that work is happening throughout the agency to understand how programs may be affected and what we can do about a variety of different things that might happen. And I appreciate your comments. I think that throughout going back to the task force that y'all were both on, so super appreciate the fact that there are task force members here today to help this continuity. You know, the transparency around the development of this program and the operations of this program has been, I think, a really central goal of our team's work, and certainly will continue to do that. And I think it's a big reason why we wanted to create the OBAC and make sure that there's an easy venue for this and for us to go into more depth. And so when proposals, more detailed proposals exist that allow us to talk about the impact in a more understood way, I think that will be a venue for that as well. So in addition to the other communications resources.
Well, thank you so much, Tim. Very much appreciate your time and expertise today. We are going to move on to our next presentation by Lisa Pearson, the chair of the Advancing Consumer Experience, or ACE subcommittee of the MAC. I will want to acknowledge that this is Lisa's last meeting of the MAC, and to want to express how much we've appreciated your time on this committee. I'm not sure how many years you've been on the committee, but you have provided just invaluable experience and insight and hours and hours and hours of your time. It's really quite impressive, your dedication to this committee and this process. So thank you so much. I know we always wish you the best of luck with your new adventures, and I'm quite certain you will be finding roles of advocacy where you land. But so I will pass it off to you to tell us about the ACE updates.
Yeah, thank you, everybody. Yeah, I'm gonna miss this committee probably most of all the ones. Well, the ACE too. I mean, the subcommittee ACE, but yeah, it's been very rewarding to be here because I think things happen here. So anyway, let's go on to our update from the ACE committee from this month. So we had 5 members attending, but we did add 2 new members this month. We talked about, we do our consumer roundtable first, which is where the members of the committee bring their issues to the table, and we decide what things need to be taken up to MAC. So Ruth McEwen is a longtime member of the ACE committee, and is very interested in the agency of choice process that's been happening. Ruth was feeling that, you know, the agency of choice implementation process has been going from bad to worse, said that the Rules Advisory Committee was coming up on December 13th, but the agency of choice committee was left out of preparation for that meeting, and was concerned about how this could affect consumers because that's the agency of choice committee had the consumer voices in the process. Ellen Penny, who is our state ombuds, clarified that agency of choice process was passed via legislation, and that the Rules Advisory Committee is there to implement the legislation that was passed. So offers to follow up on this issue offline with her office were sent along as it is outside of OHA with another agency. So Ellen was offering to help consumers re-engage with that process, because sometimes it feels like, you know, when the actual decision-making committees are put together, that they forget about the consumer members who were involved in the process up to that point. So sometimes we feel left out of the final smoke-filled rooms, right? Which aren't smoke-filled anymore, but you know, that's the colloquialism, right? So, you know, I brought up a problem with non-emergency medical transportation. In my region, in my CCO, we've only had one provider for NEMT for a very long time. In fact, since the CCO existed, it's been the same NEMT provider contractor. And so there were a lot of delays, and I'm on my community advisory committee for this CCO. I'm also on the board of directors for the health plan that provides it. So we had raised the issue of NEMT being a real problem in our region. partially because there hadn't been a lot of oversight from the CCO into that process. They had just kind of assumed this contractor was handling everything, which turned out not to be the case. And so they added, our CCO has added Lyft and Uber for rides to medical appointments specifically that are last minute, that can't be scheduled through the ride line provider. I and others on the CAC have recommended for a very long time that NEMT should be available online, that people should not have to call a phone number and then be on hold to try to schedule rides. There is a pilot project up right now that they are test driving with members about using an online portal, right, for the first time in many years. So that is in progress, which is great. We also talked about the fact that, what federal law spells out as an expression of dissatisfaction with services is usually relayed to consumers as a grievance or a complaint. And so they sometimes are reluctant to file what they feel is like a lawsuit. Basically, they think a grievance or a complaint is something bigger than it actually is. And so we might need to make better language around what, expressing a dissatisfaction with services is labeled, because sometimes people are discouraged from doing that by the terminology. I had a specific instance of a person who didn't get picked up from a medical appointment. Her medical appointment was supposed to end at 5 o'clock and it ended at 5:15, and her ride line driver just did a ride by and left when she wasn't in the parking lot. She ended up not getting home till 8:30 that night, long after the office had closed, and the ride line had to actually schedule her a new appointment from scratch. The contractor that left her wasn't picking up the phone after 5 p.m. So there's those sorts of just technical oversight issues that it might be something that the state wants to put more requirements around in CCO 3.0 for CCOs to be more responsible for delivery of services for NEMT, rather than just assuming that the contractors are going to take care of all that. Ellen Penny also strongly suggested that the ACE committee invite the lead for the state NEMT technical advisory committee to come speak to us on this issue to the consumers on our committee. Questions should be, what are you doing? What changes are you suggesting at the state level? And another of our members said it's important to focus on the populations that need NEMT for frequent provider visits, like refugees and others that have significant medical needs. We went on we're trying to come up with some draft meeting agreements, guidelines around how we conduct our meetings. And, I felt that meeting agreements can help the group create a place where everyone feels safe in sharing and come into conclusions we all agree on. Other members said, it was important to also add goals for our meeting agreements so that we can have them aimed toward outcomes that we all feel are both fully informed by all the members and also well directed, right? They aren't just scattershot. Ellen Penny stated that to ensure that one of the goals should be to ensure that consumer experience and voice are always front and center, and that a goal for the subcommittee might include both documentation of consumer raised concerns and a statement about what's going to happen to address those concerns, right? And I think that may be something that at MAC we want to work on the process a bit about, how we get return information about consumer issues that are brought up from ACE to MAC. Sometimes it's happened that we've raised concerns that we're not quite sure where they've gone because they go to something like Oregon Health Policy Board, or they go to the NEMT Technical Committee or somebody else, and we don't always get answers back down to the ACE. So the consumers feel that, they raised these issues and that maybe they never got addressed. We aren't sure whether anybody actually looked at what we were saying and responded in a formal manner. And I think that that's something that OHA could work on and this committee could work on, is making sure that a formal response is sent back to formal issues raised. what Ruth said, that, we need to make sure the meeting is open and people feel comfortable sharing with us. And we do need to do that. Make sure that all voices can be heard, even if they aren't voiced in the usual manner, because consumers don't always speak in bureaucratese, right? But we want to make sure that it's respectful, that everybody feels safe, and at the same time that everybody feels like their voice is being heard. So there's that balancing act between telling people how to talk and letting people talk, right? So that's what we've kind of been working on. Um, you know, one of our members said they should align with CMS's purpose of the back, and the back is going to be the Beneficiary Advisory Council. I'm trying to say that right. It's not committee, Beneficiary Advisory Council, which was established by CMS as a permanent consumer committee for every state to have. And so our ACE is going to transition into being that, since we were already that's the work we were mostly already doing. And we added that members can disagree. Intention doesn't equal impact, but we need to make sure that everybody feels safe, right? So we're working on that again at this meeting. We had an update on health-related social needs from Jesse Wilson at OHA, which was very informative. Cynthia wanted to know, is there a requirement to have an interpreter? And Jesse said, yes, providers are required to provide complex information in a culturally appropriate way. This includes access to interpretation services. So we've heard a little bit more about that this morning as to how that process is going to be carried out. Request forms are currently translated into 11 languages, according to Cynthia. And she wanted to know if someone living with a family member or friend who qualifies for HRSN get rental assistance. And so we are looking into how these people would be. An email followed up from Jesse, who was giving the presentation, and said, for a member to be eligible for HRSN rent assistance in a doubled up setting, the member must obtain written documentation of tenancy. And this can be a lease or written agreement, which includes the element included in the HRSN landlord agreement form, which is available on the HRSN website. When a family member is doubled up in the home of another family member or friend who are themselves the tenants on the landlord's agreement, it must be completed by the property manager or landlord who oversees the primary rental agreement. So this is coming into play. People are tripled up in housing because of the shortage, and so how you deal with people who need assistance who may not already be on the lease, right? It says when a member is doubled up in the home of a family member who owns the home, the homeowner must provide a signed lease or landlord agreement before the member can be eligible for HRSN rental assistance. So it's all those little paperwork requirements, dotting the I's and crossing the T's about who can actually get rental assistance through HRSN. And we added, like I said, we added 2 new members to the ACE this month, who will probably stay with us to be members of the back, and that is Steve Fritz and Mike Sutton, who we added to our membership this month. So I think we're up to 8 members now, if I'm correct on that. And so we are adding people. Yes, I am leaving I'm leaving mid-January, but I'm unfortunately going to miss the January MAC meeting because I'm flying. So it's been great being with you all, and I hope that the work continues. I hope we keep including consumer voices to the level that we have been, and improving that. And I just have to give a shout out to Ellen Penny, our state ombuds, for being a world-class champion of consumer voice in this process and with OHA. So I really appreciate everybody being interested in what consumers of Oregon Health Plan experience and what they've had to say. So does anybody have any questions?
Thank you so much, Lisa. We're just have a couple minutes before our break. And yes, I think we all want to commit to continuing to have the even more consumer voice for this committee. I agree, that is absolutely critical. But any other comments for Lisa's presentation or questions?
No
Okay.
questions. As always, she's super thorough and you're going to be missed. And thank you for your service. You're a rock star, Lisa. I'm going to try and recruit you for some other things.
Well, if I can do anything in another state, I will be happy to do that. But I'm thinking about going and looking after the welfare of whales instead of humans, because I think looking after the welfare of humans the next couple of years might be very discouraging.
Well, the whales need us as well, so I will happily support you putting your energies to the welfare of whales. The welfare of whales is tied to the welfare of humans, is my very strong scientific belief. So thank you again, Lisa, for all of your service. And we are going to take a break for 10 minutes and resume at 10:30. Thank you, everyone. Hello, welcome back, everyone. So, so now I'm inviting members of our health-related social needs team, Anona Gund, Tom Wonderbro. I'm sorry, did somebody say something? Okay, sorry, I thought I heard something. I thought maybe I was actually on mute. And Carissa Young-White to review our health-related services program and the health-related social needs benefit. So Anona, Tom, and Carissa, thank you for joining us, and I will turn it over to you.
Great, thanks. I'll start, and then I'll ask my colleagues, Anona and Carissa, to introduce themselves as we go. My name's Tom Wonderbro. I use he, him pronouns. My job title is 1115 Medicaid Waiver Manager in the Medicaid division of the Oregon Health Authority, and I co-lead our work on the health-related services program. Can we go forward one slide, please? Oh, I think, so this is a different presentation. This might be the health-related social needs presentation that's going to go later. We were hoping to talk about health-related services first.
I'm so sorry about that. Give me one quick second.
No problem. So while those are coming up, the reason we're here today is generally to provide an overview of those two programs, health-related services and health-related social needs. They have very similar names, which is a bit unfortunate. But health-related services is something that we've been operating in Oregon for over a decade now, and health-related social needs is fairly new under the waiver that was approved in 2022. And the reason those names are so similar is that our federal partners insisted on using the name health-related social needs, even though we already had a very similar acronym of health-related services existing in our program before. Another acronym, I'm just going to keep talking through these here that we'll see on the slides that we'll use a lot, is OHP for the Oregon Health Plan. That refers both to folks who are in the open card population as well as those who are members of CCOs. And we'll also talk about the waiver itself, or the demonstration waiver, or the 1115 Oregon Health Plan demonstration waiver. Oregon has several waivers that are all 1115 Medicaid demonstration waivers. We will be talking about the Oregon Health Plan waiver today. I can keep going if folks are okay without any visuals, because I know what I'm talking about, but it might be easier to see some of these things, and I'd be glad to pause also.
It sounds like Anona has the slides. Are you able to share those, Anona?
I don't believe I have permission. Oh, no, share screen. There it is. It has popped up. So yeah, I'll get that up.
Thanks so much. Appreciate that.
Great, thanks, Anona. This is our agenda for the day. As I said, these are our acronyms that we will be using a lot. But really the idea is to give an overview of each program and kind of compare and contrast the health-related services and new health-related social needs programs, and kind of show how they're complementary in this space. And we want to leave plenty of time for questions at the end also. Next slide. So I'll start with an overview of health-related services. And these are, it's a federally defined term. These are defined as services who help improve a member's health or community health or a health system, but it's not something that's covered under the Medicaid program. So CCOs aren't required to provide it the way they are required to provide all covered benefits. But nonetheless, all CCOs do some form of health-related services. There is no separate funding source. There's not a grant that CCOs are given to do this work. And for that reason, there's also no kind of requirement on the other side. But we do financially incentivize CCOs to spend in this space. And there's two different ways they can do that. They can spend on individuals, what we call flexible services. So that will help kind of an individual's health specific to their conditions and environment or their families. And the other part of the program that was kind of new under our last 5-year waiver period was what we call community benefit initiatives. That allows CCOs to work with partner community benefit organizations to focus on community safety and preventive health at the community level. Next slide.
And Tom, I'm just going to throw one little point out there. Flexible services, yes, we know some CCOs call it flexible funds, flex funds, all referencing flexible services under health-related services, even though you might see those different terms.
That's right. Thanks for calling it out. Flex funds mean something else in slightly different environments too, but folks have been using that term in this space for quite some time. And this can really, so what it can look like is different. The flexibility of the program was intentional, but that means that there's some variation in the program across the state as well. The process that each CCO has can be slightly different, but OHA does require that CCOs make information available to their members about how to request health-related services. And often the preferred route is just picking up the phone and calling customer service and talking through the request that way. There are CCO websites, have different forms, and they do look different for different CCOs, which can be a challenge from the member perspective. And one other thing that's really different about things in this space is that these start to feel like covered benefits for a lot of folks. But just as a reminder, since it's not a covered benefit, there aren't appeal rights when there's a denied flexible service. Members still have the ability to file a complaint, but they do not have all the same abilities that they have with the covered services.
Thank you, Tom. Just to jump in, I see that Heather has her hand up. Were you hoping to jump in, Heather?
Oh, sure. It was on the last slide. Tom, sorry, just a little clarification. I saw, okay, thank you. That CCOs use their global budget, but then they also get money in incentives. Does the incentives have required spending categories, or is that just open funds to use however they want, or do they have to roll it back into the HRS? I was just confused about that because there's two financial sources there.
It's more like a reward. So it's the CCOs receive a global budget and they can choose to spend $0 on health-related services. But if they do choose to spend, then they'll get some of that back based on a few different factors. The way it comes back to them is through what we call a performance-based reward. I won't get too into the weeds, but there's the kind of positive money coming in. There's also a thing that gets calculated for CCOs. It's called the medical loss ratio, or the Medicaid medical loss ratio, MMLR. So this kind of counts positively towards that. But they don't get any money unless they've already spent it, and then they're kind of incentivized based on that spending. They're given a reward back.
Okay, and is that cover a percentage, or is it 100% incentive to what they expend, or that's just my curiosity? Thank you.
Great questions. I'll direct you to, I mean, and we could get into them. I don't think we have those to post, but our final slide is on resources. It includes a link to our webpage, which has our 2023 spending hot off the presses. I think it came out last week or 2 weeks ago. And it does have those details. There's a tricky answer to that. It's based on kind of some quality and other things. CCOs have to do other things right, and they have to do the right kind of spending in other ways to get the right kind of money back. And then when they do that, yep, exactly. They could get more than $1 when they spend $1 this way if they do everything correctly. Not everyone does. It's not exactly 1-to-1, but that's kind of the reward system with some factors.
Okay, that's very generous. Okay, thank you. I will take a look at those slides.
Thanks. I think our next slide introduces the health-related social needs, so I will pass it on to Teresa and glad to answer any other questions later.
Thanks, Tom, and thanks everyone for being here today. My name is Teresa Young-White, and my pronouns are she, her, hers. I am a analyst with the Oregon Health Authority, and I am somewhere about 40. I don't like to be too explicit, and I have brownish hair and glasses. I'm a white woman, and I'm wearing a very colorful top of the colors of the rainbow, actually. And I just really appreciate you having us here. So health-related social needs. This is a brand new benefit that started in 2024 for eligible Oregon Health Plan members. And it is part of the 1115 waiver demonstration. So the waiver, like we had on the abbreviation slide. And we want to be really clear as we talk about health-related services and health-related social needs. When you look at the acronyms HRS and HRSN, it seems very similar. And both benefits do cover sometimes social needs as well. But health-related services and health-related social needs are completely different funding streams. And the health-related social needs benefit certainly impacts health-related services, flexible funding streams, but it doesn't replace it, and it's not intended to it's intended to be in addition to health-related services. So through health-related social needs, there's very specific benefits that are covered. I'm going to talk about all of them in just a moment, at least at a high level. Climate equipment, housing-related supports, and nutrition will become a benefit on January 1st, 2025, actually. So that for health-related social needs, there's a benefit eligibility framework, which means that the people have to be an Oregon Health Plan member, and it's standardized throughout the state. All 16 coordinated care organizations, or CCOs, and Oregon Health Authority's Open Card must implement health-related social needs in the same way, based on the rules and the requirements that we set in the Oregon administrative rules and the contract, etc. So health-related social needs is really an entitlement. It's a little bit different than the health-related services like Tom talked about, where the CCOs have discretion to spend a certain amount. And I won't talk about the performance part that Anona's putting in the chat, certainly. Let's go to the next slide and we'll talk about health-related social needs benefits and eligibility. So high-level overview, we just want to be really clear that when we talk about the health-related social needs, I use this word again, I'm going to say it again though. I use this word once, I'll say it again. It's an entitlement. So if a member is an Oregon Health Plan member and is part of one of these HRSN eligible populations and has a health outcome and a social need for these services, then they are eligible. They do receive that benefit. Of course, the next step is they have to ask for it, or someone needs to reach out and support them asking for it, at least. So it is, if they're qualified, they do receive it, no matter what health plan they have, what CCO or Open Card they have. But this clinical risk factor is a really important piece for health-related social needs. We really are capitalizing on this health-related, right? So we want to impact housing, being safe in your home. We want to impact the nutritional supports, etc. But it really is related back to a health outcome. And it must be. The health outcomes, though, or the clinical risk factor, it's very broad. It's people with complex physical health conditions. It could be diabetics that have a complex health condition. It could be a behavioral health concern. So someone with substance use disorder, potentially, that is impacting their ability to access these social needs that they need. It could be developmental disability. There's a list of these HRSN eligible, or I'm sorry, HRSN clinical risk factors, but it is intended to be pretty broad because we know we can connect social needs to this health outcome through this clinical risk factor piece. But that is an important distinction. With other benefits, they don't always have this clinical and social risk factor eligibility criteria. So there's a lot more details on the eligibility framework. I know we've talked to this group, my team. I don't think I actually have, but at least I was talking about Jesse earlier. So you might have some overview of that and links to some eligibility frameworks if you want to get into depth on each benefit's eligibility. Yeah, Heather, plan members who have complex needs are eligible. You know, I don't want to say yes, everyone, but yes, that's the intention. It's people going through life transitions and challenges, or people that have gone through life transitions and challenges that are continuing to show up in their health, impacting their health. Absolutely. And I will make sure you get that eligibility framework for sure. I'll show you where it is on the resource slides in a little bit. So just as far as a timeline, I mentioned this, climate, equipment, and housing related supports are live, really exciting. Housing went live on November 1st. So those two include outreach and engagement services as well. Outreach and engagement services are a little bit of a behind the scenes benefit. They're intended to invest in community partners, especially community-based organizations that are doing work on the ground, supporting connecting members to other resources, including social needs or preventative health care and others. And the outreach and engagement benefit is meant to pay those organizations for their work doing this. It doesn't necessarily rise to the member level of awareness because it is really focusing on wrapping health navigation and that kind of resource connections around the member, which a lot of these organizations already do. But it's a really important piece of this benefit, so I wanted to talk about it a little bit today. And if you're interested in more information on any of this, please email me, but I'll put that in the chat. And then in January, the nutrition benefit goes live. Like I mentioned, that is medically tailored meals and nutrition education only for now. Pantry stocking and a fruit and vegetable benefit will be coming later in 2025 or early 2026. So young adults with special healthcare needs are also eligible for HRSN as of January 1st, and they weren't a covered population before. So I wanted to make sure I mentioned that. And let's go to the next slide, please. So specifically, what is the housing benefit? The housing benefit is for people that are at risk of homelessness. And there is a definition of that, lacking resources to stay in their current home and having an income that is 30% below the area median income. You don't need to remember those specifics, but there's other resources that point to that. We do use the Department of Housing and Urban Development's area media income to develop the eligibility for this. But for folks that are eligible because they're at risk of homelessness, plus they have that clinical risk factor I talked about earlier, they can get rental assistance for up to 6 months. If they're approved for rental assistance, included in that could be utilities if they need it, and storage fees potentially. Lisa talked a little bit about being doubled up. That's one of the things that rental assistance can really help with. If someone loses their home, but they're staying with a family member or friend or whoever it is, and they are stably housed for now, but it would really support their situation to get help with storage. Maybe they don't have as much room when they're staying in an additional bedroom, or couch surfing is another way to look at it. They could get support with that. Also, they could sign a very, very small, we even have a template for it, rental agreement with someone that, say, a family member owns their house. And maybe it would help the situation if the family member was able to get a little bit of funds to keep that member there longer, right? So hopefully this rental assistance will help keep people in their homes. There's also housing tenancy sustaining services, which is basically housing case management that Oregon Health Plan pays for members as well that are at risk of being homeless. And then the last benefit for housing is medically necessary home accessibility modifications and remediations. That is a huge mouthful. Sorry for all the big, we like to call it home mods, but it's basically updates that are needed for the home to help the member that's related to a health condition. So a good one is a wheelchair ramp. Someone that has a physical disability but doesn't have a wheelchair ramp in their home, and maybe the landlord is not required to build one, maybe there's no other way to fund this, then they could be approved for this home modification. Other things include like grab bar installation, pest control that is not the landlord's it is not required by the landlord to take by law for the landlord to take care of it. Like something like bed bugs could potentially be covered, heavy duty cleanings, and then if someone had to stay in a hotel during one of these accessibility changes, updates to their home, then they could potentially get approved for hotel stays as well. Okay, next slide, please. The climate benefit is a lot simpler than the housing benefit. This is for any HRSN eligible group, so people that have been in child welfare in the past, people discharged from a behavioral health facility or incarceration. Any of these groups that have a clinical risk factor that could be improved by, let's say, an air conditioner or a heater, then they are eligible for this benefit. And this also includes air filters or air filtration devices as well. So air filtration devices to start up, and then you could get air filters later on in the benefit, for instance, and then portable power supplies and mini fridges. That has to be in relation to either a medication or medical equipment, but those are also potentially covered benefits. Let's go right on to the nutrition benefit. I kind of touched on this already because I forgot this slide was in here because I don't talk about it as much because it's not live yet. But medically tailored meals and assessments will be live on January 1st. Medically tailored meals include a visit, or the assessment does, but it's required to have a registered dietitian assess the member and develop a plan for medically tailored meals. And then nutrition education is a very wide swath of things. So anything that can help, not anything, but a lot of nutrition education, anything that can encourage, provide tools, cooking classes, anything that encourage is healthy eating in a positive direction. Heather, I see your note. I apologize. That's not only for those populations. Those were the examples I brought up. It's also for people that are transitioning to becoming duly eligible for Medicaid and Medicare. I know a lot of you know all about that. It's carceral foster care, at risk of homelessness, being homeless as well as being a young adult with special health care needs as of January 1st. So for the climate benefit, it is any population you've heard of in relation to health-related social needs, those are all eligible for the climate benefit. Housing is just really specific that need to be at risk of homelessness. That's the eligible group, which is why I brought it up there. Okay, I'm all done, I promise. But I just wanted to more provide these resources, less than talk about this slide. But this is, if you're a coordinated care organization member or working on behalf of someone who is, the best thing to do is you can go to the Oregon Health Authority's webpage and click on our housing webpage or climate webpage. There will also be a nutrition one. And you can click on your CCO's request form, and then it goes directly to them. A lot of them are using like a cloud-based form through their social determinant of health referral platforms. For instance, you might have heard of Unite Us or Find Help. A lot of them are using that. Some of them are PDFs that they ask you to attach to an email, but they're all slightly different. They're all operating under the same requirements, but their processes could look slightly different. So probably the best thing to do for coordinated care organization members is to go to directly to those forums or call the CCO. For open card members, we also created a request form, and those just get emailed off to the email on the screen. And all of that information is on these forms and on these links as well. All right, any questions before I pass it back to Anona to sort of wrap all of this stuff up? Okay, thank you.
Tony, looks like you have a question.
Yeah, no, thank you all. I know it's a lot to cover, and I think just the eligibility is kind of the question that I'm struggling with in all the different programs. And when I look on the main website, I see that the overlap on OHA's website for health-related social needs, it has all four there, and it says who will qualify. And it appears to me that that eligibility is the same for the housing. And I guess my clarifying question is, you're saying that there's different eligibility for nutrition versus climate. Is that correct?
Yes, that is correct.
It looks on the website, and I'm just briefly looking right now, that it has the four above, and then below, and I'll post the website here that I'm referring to on OHA's site, that it seems to me to be maybe a point of clarity related to those. And I would just call into this that I brought this up. A lot of this is being disseminated information to community-based organizations, those that are in housing or those that are in nutrition. But a good point of access to care is for the health systems that people work in, and when they come across these issues. For instance, if I have a patient with asthma, or if I have a patient that has struggled with housing, referring to that. Just a reminder, just how we continue to distill this information down in readily usable format for all of those locations. Because I would just say that, my clinical setting, we have some support for some outreach workers to know some of these nuances of this, but a lot of providers, I think, aren't fully aware. And as we've added these on, the level of complexity has come up, and I've been on a multitude of these meetings, and just seeing kind of bringing it all together is tough. So I'm sure for the broader audience it remains that way. So again, I know you guys are doing phenomenal work, tremendous work in getting that information out, and it's a struggle. But just a reminder again that it'll have to be ongoing work with that.
I hear you, and thank you so much for bringing that up. And yes, that is the best website. There is a service provider website as well. And I hear you as I look at that. I'm actually doing an audit of our webpage right now. So this is perfect feedback, and I appreciate it, because who will qualify for these services? You have to be in one of those groups to qualify, but that doesn't mean you do qualify, right? And so I just totally understand. And this has been very complex. And to be transparent completely, it has been sometimes we think it's a little too complex here too. So, but I hear you, and I think we'll make some updates to that. And then I do want to comment that if anyone would like to meet with me, I would be happy to, and sort of go through eligibility in a different way. We're doing these informational meetings, so please reach out. I know that doesn't solve everything, because we want things available for people to understand without having to take an hour to meet with OHA, certainly, but just know that we are available. So thank you very much.
All right, I'm going to wrap us up. I'll try to do this quickly. So hi, I'm Anona Guns. I'm a senior policy analyst with OHA's Transformation Center, and I co-lead on health-related services, not HRSN, but HRS, with Tom Wonderborough. So some of you may have seen this slide before. We've used this in quite a few health-related services presentations. It's really just saying there are multiple ways that CCOs can invest in their members in their communities. The broader community, outside of even OHP members, there's that population level investment CCOs can do through that HRS Community Benefit Initiative spending. When we look at all of our OHP members, there's those subsets of all the CCO members that can request HRS flexible services. Though some overlap with our HRSN eligible members, but there's also not always overlap, because not all HRSN eligible members are CCO members. There's that fee-for-service piece that fee-for-service folks, open card folks can't access health-related services, flexible services. So how do these compare? We created this because you're right, it's confusing. Almost the same acronyms is super frustrating internally to OHA, externally to OHA. We're working on that for the next round of contracts, hopefully. And so this is sort of our side-by-side comparison. HRS is not covered, while HRSN is. So covered benefit versus non-covered benefit. At the member level, only CCO members can request HRS flexible services, but HRSN, it's any OHP member. At the community level, we do have HRS spending that can happen. It can often happen through grants to partner organizations. But HRSN, they do have those community capacity building funds also through grants, but this is sort of a limited short-term piece that's happening as the waiver is implemented. I will say that covered benefit versus non-covered benefit, it's already been spoken to a bit. HRSN required benefit for eligible members and paid for with the state Medicaid budget, while HRS for CCOs, it's paid for with the CCO's Medicaid budget and has been available in Oregon really since CCO started, whereas HRSN only started to become available in 2024. They both are going to have housing, nutrition, and climate device services and supports potentially. But HRS will go beyond that. So HRS has the ability to do other things for folks who are not eligible for those HRSN benefits, or who are eligible for HRSN benefits, but then also need supports outside of housing, nutrition, climate devices, or outside of what's actually covered for those things. So HRS really has the capacity to sort of fill the gaps for members in ways that HRSN, may not be able to cover something. But again, it is only for CCO members. And they really are both intended to improve overall health and well-being for folks. So I'm gonna give you a quick example. You have a member who needs 2 months of rent to maintain their housing. They meet that definition of at risk of homelessness. But whether or not that member meets all that other eligibility criteria for that specific benefit will decide really, is it an HRSN covered benefit, or can the CCO choose to use health-related services, flexible services? Once HRSN, when they meet all that other eligibility criteria, again, it's that entitlement piece, the CCO must provide the service, and the member will have appeal rights if they're denied the service. Once HRS flexible services, the CCO can choose to fund it. It is at their discretion, and the member will not have appeal rights, although they can submit a grievance. However, as we heard prior, that can be a daunting process. It can sometimes be a slightly inaccessible process. There are language access issues, and so being able to submit that grievance isn't going to necessarily solve things for a member. And that is the example we have. I'm not going to run through this entire slide. There's a lot of information here. And when you have the PDF of the slide, you can click on the link where it says here is a resource, and this is a screenshot from that resource. Essentially what we're trying to say is that CCOs are able to use, okay, you've got some members who are eligible for this covered HRSN benefit. You have some members who aren't, and we can use HRS flexible services, and we can also invest at the community level to sort of more holistically support members in communities. We hear a lot where the gaps are and where needs aren't being met. But I would also just throw out there that yes, that is true. And also there's a lot of spending happening. CCO spent over $120 million on health related services in 2023. I don't know what 2024 is going to look like, but we've been seeing continual increases since we started. CCOs have had the ability to do that population level investment, and we've been tracking it. And so since 2019, it's really continued to increase. So it's really a both scenario. Not all needs are being met, and also there's a lot of spending happening in this space. And thank you, Trissa, for answering the question. The question was, are HRSN a capped budget for CCOs? And the answer is no. It is not capped at the CCO open card level. If a member is eligible and requests those services that are covered under HRSN, they are entitled to it.
So I'm sorry, so so that means that the CCO has to reach into the global budget if they exceed whatever equation amount they were projected to get from the HRSN. I mean, it's just it's so complex, and CCOs are all doing this very, very differently. So I guess just to give you context about my question, it makes it very difficult. And then, as you said, the grievance process, it makes it very difficult in the rollout for providers to support members they're serving in accessing these services, because they're all done good enough, but differently. Or maybe not. And then how do you collect, how will your teams, because this is complicated enough to roll out. How will your teams analyze the population health benefit with all this diverse, flexible spending? And how we're moving the needle on health equity. I guess that's the big question. And we brought this up in the MAC before. It's like, how do we tie the knot on this really lovely, flexible spending, which then makes it really hard to collect population health, meaningful outcome data? Because if, our hope is this will improve health equity, especially for vulnerable, complex cases, but I'm not seeing how we're going to collect that data in a way that demonstrates that we're moving the needle in an effective local, regional way for particular populations. So I guess what's your thoughts, or is that another presentation, or
I just want to jump in here. We are over time on this topic already, and I know this is, I think, partially related, parallel to Tony's presentation. Tony, do you feel like this that we can continue here for a few more minutes, or do you want to dive into yours? Go ahead and continue. Okay, thank you. So thank you for that thoughtful question, Heather. Just wanted to jump in.
I'm going to jump in first, and then I want Trissa and Tom to speak to the budget and the cap piece for those actual HRSN services. You're right. HRS, health-related services, were meant to be flexible. We don't get the level of data and health outcome and impact data. You're right. We don't have that data. It's not there for us to necessarily evaluate in the most rigorous way, which was somewhat intentional so that CCOs would actually spend in the space and we don't create this huge administrative burden for them to actually spend. Health-related social need covered benefits were sort of proposed in this current waiver because we knew there were gaps with flexible services. We knew there were some equity issues, and the goal was to start having some of these actually be covered required benefits for members in a way that will address some of those equity and access issues. And there will be, you're right, that is where we are going to get more rich data to do that evaluation and that impact. But you're right, there is still going to be that challenge of how do these two things together impact health in a positive way. And there's some things that can be done, but you're right, it's still, there are a lot of limitations to the data, and it is just going to be challenging. And I really want to defer to the waiver evaluation folks on the details there, because I won't speak to it as eloquently as they would. But you're right, that is a challenge, and it's something we still need to be working through. And I'll let them speak to that, the budget piece.
Yeah, and just ditto, I just agree. And I think if you wanted, not me, but our team to come back and talk about evaluation and data and how they're connecting that would be great. Again, that's not I think I understand it, but it's a lot different. But on the budget, really quickly, I wanted to let you know that CCOs in the first year are running a non-risk. So they do not have to pull into other budgets. So it's a non-risk. I know that this is really complicated for a lot of folks. But it means that what they pay out, they're going to get back. And they also have additional administrative funds that are probably, if I recall from our finance folks, a little bit higher this year. And for the first years as they implement, so they can account for administrative, additional staffing and resources. So that's not always going to be a non-risk situation and contract with the CCOs, but right now it is. And then the piece about the budget, Vicki, are there any caps on the amount of rental assistance members can be approved for? There's a wide range of rental costs. Absolutely. It does account for that. So what we're looking at is we're looking at the regional, when they built the fee schedule, they have a lower limit and an upper limit. And it's based on the region that people are in. So someone in the Tri-County area, if the average rent is like $2,500, then CCOs or open card can pay for that rent up to $2,500, and actually it's 150% of that. In fact, I don't know why it's complex like that. And then maybe in a lower rental area, there's a different range, but they are looking at it on a cost-based perspective. So they have a lease and they have that monthly rent in front of them, and they pay that monthly rent as long as it's not over this upper limit that I'm talking about. So I wanted to make sure and answer Vicki's question there. And I think that's it. Thank you.
Great. Well, thank you so much for this vibrant discussion. I agree that it's really complicated. I'm not going to lie, I'm pretty lost in the details of what is covered when and the eligibility. But I think that is well acknowledged and outside of specific control. It's not like anybody can just maybe wave the wand, sorry, my dog is barking, and make that go away. Apologies, I have a very protective poodle. So we'll move on to Tony, and I will try to silence my dog. Thank you.
We couldn't hear that much, just FYI. We did have some slides, if we could bring those up. Maybe one day we'll all live in a state where everybody is eligible for the same items, and we'll keep working towards that, simplify the system. I really appreciate the MAC's opportunity to join all of you here today. I was asked to come and speak some of the charge that Oregon Health Policy Board has been asked to do a look on how we are thoughtful to the 2027 CCO procurement process and that contract that will be taking place. And I really appreciate our committee and the MAC and all of our committees' attention to this body of work, so we can do some investigation to make sure that we're doing well when we look into that next contracting. Again, my name is Tony Jerome. I use he, his pronouns. And a member of the OHPB. We can jump into the next slide. And I'm going to probably go through these a little quicker just in the interest of time for more discussion and the questions towards the end, which is the goal of this. So the really agenda of this presentation is just talk a little bit about the 2027 procurement process, talk about some timeframes and how we're hoping to shape that discussion and engaging broad swath of input and feedback. The purpose, again, is just really to inform decision-making for the Oregon Health Authority in that contracting work with the Oregon Health Authority and the coordinated care organizations. And we really appreciate the feedback from anybody and everybody, and trying to get out to as much of the network and to Oregon as possible to understand what drives CCO's successes and help develop models that we can use across the state for that next CCO contract. Next slide. Just a brief overview to ground people on CCOs. There are currently 16 coordinated care organizations in Oregon. They serve 1.4 million Oregonians. They're very heterogeneous, and one is not necessarily the same as the other. Membership can be, for one CCO, as small as 18,000 lives, and it can be upwards of 456,000 lives. The service area could be for one county, or it could be upwards of serving 12 counties in Eastern Oregon, according to care organization. They serve a number of locations through that geography. It is the same contract that we're looking at, but payment rates do vary geographically depending on the needs of that community and how to serve that community best. As mentioned, the current contract is taking place. It began in January 1st of 2020 and extends to the end of 2026. Go to the next slide. In this process, OHA is, launching this plan to review, and with that, it has a couple areas to focus in on, and that is setting clear expectations for potential CCO applicants through a formal procurement process. They will be evaluating applicants in alignment with those expectations and award the CCO applicants with new contracts starting January 1st of 2027. Next slide. This is really important work, and why does it matter? Well, these are some of the largest contracts in the state of Oregon. This ensures that 25% of Oregonians currently get their health care through OHP. We're hoping to align these with Oregon's goals for Medicaid. Also, the timing of this takes place that the new 1115 waiver will take place in 2027, the same time this comes online. Hoping to leverage CCO's performances and reset expectations so that we're going to move forward as a state with delivery of care. And this is a key time that we can promote best practices in places where we want to go with delivery of healthcare. We really want to engage communities and think collaboratively in that decision making of what needs to be included in these contracts. And ultimately, really just working towards our goals as a state that we've put on paper as far as the strategic plans for health equity in 2030 and make those real. Next slide. There are a couple approaches, and it's multi-pronged approach to feedback and input that OHPB has proposed, and really just working with our committees and with the BAC here today. I really appreciate, again, that time, getting feedback through these channels and the networks that the MAC has contact with. That will take place through January, middle of January. We did host a public town hall yesterday, which is really great conversation. Really enjoyed the feedback and community members coming to that event. We're going to continue to have an online public survey through the middle of January as well, and hoping to host a conversation about those successes of CCOs in the middle of February. And as mentioned, moved in. If we go to the next slide, we have a timeline. Just a representation. So starting on the left here, Director Hoppy came to OHPB and presented at our retreat the charge to serve as a role OHPB to gather information and kick off with that with our committees. This fall, OHA is reviewing past program performances and develop a pre-procurement snapshot of what CCOs are doing in that level of performance and the programs overall. We're going to be going into December, January here with gathering committee's work and solicit input. As mentioned, we hosted the December 3rd town hall, which was very informative. Very much enjoyed that opportunity. As we move into winter in February and March, OHPB will be compiling that input from the communities to inform the CCO procurement. Very big thanks to our staff and to the staff of the MAC and all our committees. Can't do this work without all of you. And then we hope into March hosting one of the OHPB meetings, provide a summary report to synthesize the input that we've been receiving to affirm really, again, a positive direction of moving us forward. And that will lead into, the end of 2025 and 2026 to inform OHA in that contracting work with respective applicants. Taking the next slide. Again, this is really just importance of sharing experience. The MAC really does an excellent job at this. And again, appreciate the time here today. We can jump in the next slide. We're looking at all forms of feedback and information that can help us in formulating those contracts. There are a few areas that stood out that we might call to attention is how we're kind of promoting childhood health and helping children grow and into early adulthood. Of course, we've got a really strong focus in this state and a necessary attention to behavioral health and mental health. And so hoping that we can engage and ensure members have appropriate and timely behavioral health services and how we're engaging with our health systems. And then we just had a full discussion about social and environmental drivers of health and seeing how CCOs are using the body of work that we've been doing with our 1115 waivers and other spaces that they've been working that and focusing on things like food assistance, housing programs, and other tools that they've been using as something, a call out. Next slide. Some of the discussion, something to be thoughtful to is, sharing experiences of successes, but also the challenges that people are facing. What factors do you think that made the experience a success, or what were the challenges that led up to that? From individuals or health systems or clinics and providers' perspectives with CCOs, are there aspects that have helped improve care? Focusing on what is that level of communication? How are we understanding where eligibility is and how are people getting that out? And ultimately, really delivery on good health outcomes is what we want to see. Again, where have we seen successes with CCOs and specifically what is making that success possible? and share examples of models that are taking place so we can take those best practices and share among the body of work across the state and promote that. Next slide. We did have some questions just for targeting providers and provider groups, just some general suggestions to consider. Particularly interested in, some of the administrative burdens that are taking place. We all know those all too well. So just seeing where we can navigate those waters more efficiently. What has contributed to a better experience for providers? What are those things that are leading to successful relationships and some of the tactics that are taking place in our state? Some of those questions, just in your experience as a provider organization, what are some of those successes and challenges? Very basic, prompts. Yeah, I think we'll just jump on to the next one. I think that comes to a close. Just, really appreciative of this work, Mac taking up as well. Chair Brenda Johnson, Vice Chair Kristen Isaacson, and myself for the liaisons to the Oregon Health Policy Board, happily be part of that. Again, just a big call out to our staff, can't do this without them. So just a bit of a framing to the work ahead in the next year or two. So thank you all.
Thank you, Tony. So we have about 10 minutes for MAC comment questions, and then we will be opening public testimony at 11:30. So if MAC committee members have questions or comments, and maybe if we could go back to some of those discussion slides, start here, these two slides, and please feel free to raise your hand or jump in to if there are specific comments or questions. Go ahead, Heather.
Caroline, I know the MAC is working on a memo letter to give to Oregon Health Policy Board members. And so I don't think I have much, and it was included in the materials today. I don't think outside of that, I have any additional input or considerations, because so many of these topics are things that we were working on in our work plan this last year and in the upcoming year. I am very optimistic about what we heard about the CLSS work that's happening and the continuous improvement and expansion of that program, because that has been extremely helpful to expand access to culturally and linguistically specific services in Oregon, of which in the behavioral health side, that's what I can speak to, because that's what I know about. We have seen modest growth where we had no growth before the CLSS was able. Of course, it is not going to be quick enough or expansive enough as people would desire, but it definitely has been an improvement. And, also for behavioral health, I would say that those CCOs that are able and have supported alternative payment structures for behavioral health to help change some of those historic structural problems in funding and oversight have been super helpful. Again, that's in the letter, the alternative payments. And then I do know the question came up today. And I don't think we talked about admin burden quite as much in the letter. But the other one is, where are there opportunities, since we chose a model where we have pros and cons, with all models have pros and cons. So this isn't a comment on the model. I'm just being very factual. All models have pros and cons. And one of the cons of our model, and also one of the pros of our model, is we have 16 separate good and enough, very differently run contracts, which for behavioral health, because the services are thinly available across the state, most of those behavioral health providers do contract with multiple CCOs, which creates an immense amount of administrative burden. It's just a fact. It's just the way it is. And that we maybe think about that when we're like, where are opportunities to streamline protecting quality and patient experience with their healthcare services, but also complying with Medicaid at the federal level and the state level, but also streamlining and supporting CCOs also with their administrative burden and streamlining those processes. It would be very, very helpful conversation. And I'm not sure where the home for that conversation is. So maybe that's something to consider. We talked about, I think one example is we talked about here, credentialing. Like, there are platforms where you can consolidate credentialing and multiple parties can log into that platform and look at who's credentialed and what. Of course, monthly reporting on potential abuse or fraud things have to continue, but that major credentialing pieces, there are now opportunities for streamlining that. Same with the interpreter access. There's a lot of new ways that multiple different business models can work with a consolidated or eased access process. So I don't know where those conversations can happen. I don't know how much we can do based on Medicaid, state and federal requirements, but I think that's an interesting place to talk about because we do know for workforce, those administrative burdens and lack of access for the resources that are the people we serve need is sometimes even more than wages is the reason people leave the field. So really trying to support the workforce and the people that we serve across Oregon.
Thank you, Heather. A challenge that I've seen routinely in my primary care practice and that I think I've heard from friends in other systems. I don't think that most of my primary care colleagues spend a lot of time thinking about CCOs other than frustration about network adequacy and trying to get specialty care for their patients and finding covered providers. I know a challenge that has routinely come up living and working primarily in the Portland area is having multiple CCOs covering the same geographic region, but not all covering the same health systems. And so, for example, coverage for physical health at OHSU is not covered by the same CCOs necessarily as the behavioral health. And so having to send patients that I see as a primary care physician to outside facilities for behavioral health care. And I think I second Heather's comments that most of what I think I would have to say from my perspective as a MAC member is being put into that letter, but my perspective as a clinician and as a primary care provider is the just frustration of how do we know where to send our patients, because we don't know, and we have to put that burden on our patients and telling them, please call your insurance company and ask what gastroenterologist is covered, and then call around and ask if they're taking patients, and then please send me a message, and then I'll place the referral. So administrative burden being a large access. What other questions do we have? We have a few more minutes for MAC committee members.
I know I have had some experience with the CCOs, both as a community member that has been pretty negative, with denial of services and things like that. But I believe I've spoken about that, previously, especially with stuff like, oh, hey, you need this medication. This is not the first one that we've tried for you, but we have to get approval through the CCO. My husband recently got a denial letter saying that before he could try the current medication his doctor was trying, um, that he had to try these other medications first, um, most of which on the list he had either tried or the CCO had already denied. So it's definitely been extremely frustrating for that. My own hysterectomy originally got denied because there were tests that weren't going to provide any further information or any further help other than to be painful and to delay the process. And my doctor actually had to go through a whole process for that, which as a consumer, it felt like the CCO was saying, we don't trust your doctor to have your best interest at heart. but clearly you are suffering and have a problem. We also don't have your best interest at heart. I think from a consumer standpoint, that kind of feels like the insurance experience, whether it is through the state or not. I think that's pretty universal for everybody. As a provider, as a doula, trying to get um on with CCOs, the experience has been at sometimes disheartening, but altogether frustrating and infuriating. I'm credentialed with Medicaid. I'm all good to go. I have everything I need for that, and I can serve open cards, but I can't serve in my home area because they say that they have enough doulas. But yet, if I join a specific group of doulas in this area, then I can get credentialed with my CCO, no problem, which makes absolutely no sense. Um, but I'm able to, outside of my home area, it's not a problem at all because the CCOs kind of make their own rules and decide how many of each doctor they need. And unfortunately, it just seems like the CCO's idea of however many doctors or different or alternative service providers they need is not matching up with service levels, because even to get to just a PCP, most people are waiting months. So like there seems to be a lot of issues with CCOs, and I personally have not, from a professional or consumer standpoint, had very many successes with them at all. So I don't know how the MAC can address that in any way, or any of the things we've really talked about today address that.
Thank you, Shannon. I really appreciate that perspective as both a patient and as a provider from a individual solo practice. I think the perspective, and I definitely think that individual practitioners have very different experiences with CCOs than employed providers, because the employed providers have layers and layers of admin that deal with those challenges. So thank you for that really important insight. It is at time to move to public testimony. I do see that Lisa has her hand raised, so I'm gonna, Lisa, have you make your comment and then we'll move to public testimony.
Yeah, I would just like to see OHA take on a little bit more oversight of subcontractors hired by CCOs, and when they do CCO 3.0, they've had kind of a hands-off approach toward the service providers that are hired by the CCOs. And those have, in our CCO, have not worked out in several circumstances. They've actually had to fire 2 contractors because of, contract non-performance. And, we still have an issue with our NEMT provider that we're working on, which has improved drastically, but I just think that OHA needs to be more involved hands-on in the process of dealing with how CCOs farm out their obligations to other parties.
Thank you, Lisa. And I saw I skipped a part on the agenda. I appreciate all of this discussion. Thank you, Tony, for bringing this to us. Yesterday, our MAC staff shared a draft letter with the MAC members to highlight areas of concern that we've identified regarding coordinated care organizations over the last year or so. If our folks are comfortable with that letter conceptually, I'd like to ask for a vote to approve it. Do I have a motion to approve? Since there's a pause, I also want to acknowledge, did people have time to read this letter, or should we defer this to the January meeting? Since it was just sent yesterday.
This is Kelly. If there's time, I would prefer to wait to have a chance to review it.
I see Heather's got her hand up.
I would concur with Kelly, and also be open to getting if anything was left off or not articulated in a manner that people feel is clear, that we have a little space to do a little editing between this meeting and then voting in January.
I like this idea as well, because I know I also was not able to read it as thoroughly as I would like. So I would suggest that all of the MAC members read this, send thoughts to Sarah, and Sarah, if you could work on that, on the comments and incorporating some of our feedback today, we can defer this to the January meeting. So thank you. So now we will move on to public testimony. Apologies for being a few minutes late. Thank you for waiting, members of the public who are here. So the Medicaid Advisory Committee welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with careful attention, respect, and honor that you deserve. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual and is not a representation of the Medicaid Advisory Committee, its members, the Oregon Health Authority, or Oregon Department of Human Services. Each presenter is given 2 minutes to share. In the event that that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we will start a 2-minute timer for each commenter. We kindly ask that commenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps. Board staff will communicate the next steps with each public commenter. In addition, please know that we will share any testimony regarding the 1115 waiver with the Centers for Medicare and Medicaid Services in OHA's quarterly report to that federal agency. So if there are members of the public who would like to speak, please raise your hand. I see Wilma Ingram had asked to give testimony. Are you currently on the call, Wilma? Okay, are there any other members of the, okay. I see Artis. Please unmute Artis. We will hear your public testimony. Thank you.
Hello, my name is Artis Smith, and I'm one of the many disabled Oregonians receiving SSDI who are losing their OHP and therefore their affordable health care in the final Medicaid unwinding group. Starting this month and over 4 months, many disabled people on SSDI making less than $17.32 a month are losing their OHP, and that's dental, vision, and many providers and treatments. 64% of people in the final Oregon group have a disability, and I'm urging you to fix Oregon's approach so health equity doesn't worsen for disabled people. The state has said Oregon's unwinding goal has been to preserve and expand health coverage for economically and medically vulnerable people to eliminate health inequity and bring better outcomes. However, the OHP limit for most is $17.32. For SSDI, it's only $9.43 through OSIPM. The average SSDI has been above $9.43 for 20 years, and the average person receives $16.80. So Oregon's limit is very low, discriminatory, and cuts off most people on SSDI, although they cost OHP much less. One told me that the state figures if you have Medicare, this is justified. It doesn't make sense to suggest that most people who are permanently disabled making under $1,700 can somehow afford 20% coinsurance, while other Oregonians rightfully have all costs covered, and people on SSDI were also left out of the bridge program. Disabled Oregonians will have to choose what care they can afford. California has fixed this, and they allow people on SSDI to qualify as others do by raising the income limit through their aged and disabled FDL program to 138% the poverty level. I'm surprised that Oregon hasn't yet addressed this, but it can now. Oregon's notices telling disabled people they're losing OHP against HB 4035 also fail to tell people about other programs they may qualify for, such as long-term services or the Employed Persons with Disabilities program, meaning that many people are losing their OHP who qualify, but the state hasn't provided the info. Please immediately pause the OSIPM unwindings and fix the program so people on SSDI are not cut off from their essential medical care. Thank you.
Thank you very much for your testimony today. Are there other members of the public here that would like to testify? Well, maybe others join us. I will read the testimony that Wilma Ingram put in the chat earlier today. Hello, everyone. I am Wilma Ingram. I have CPCCO. I wasn't helped by CPCCO. My complaint against Coastal Family Health Center was ignored. after I was cut as a patient as CFHC, being accused of some bad actions that I didn't commit. A complaint department worker at CPCCO said it looks like I am the problem. I said with no proofs from CFHC, sending me any paperwork, videos, and witness statements. I was already having a mental, physical, exhausting situation. I was abandoned after I sought help from CFHC. Thank you, Wilma, for that written testimony. Are there other members of the public? If there are no other members of the public here today, it says there's written comment on the website as well. Should we link to that and read that as well, or Jordan's going to link to that. So I'm opening that up. So I will read this as well. This is public testimony from R. Drake Eubank, who is a peer provider and consultant. I would like to speak to a new initiative and potential legislation to broadly support housing subsidies using Medicaid housing cards, which would use Medicaid waiver dollars to fund dedicated amounts housing, i.e. cards that could be issued to those unable to meet basic rental costs in their area due to inadequate benefits or income. In a recent survey that Pacific Sky Design conducted under a state planning grant, almost all of those responding stated that even if normal housing was available, they couldn't afford the amounts that would be charged on their benefit checks alone. A card system would likely require a waiver for one or more state Medicaid programs, HCBS being the most obvious. The subsidy cost to the state would be a third of its full price when including the federal contribution, and it would actually be nominal relative to the medical dollars spent per person. For example, a card for $300 to $700 per month, maximum of $8,400 per year, a $2,772 state contribution relative to the tens of thousands spent each year on medications, medical procedures, and hospital ER visits. This is especially true of the unhoused and housing insecure populations, as the instability generates additional critical medical situations and emergency procedures when contrasted with having an assigned provider and the preventative care and the non-emergent maintenance care made possible by safe and stable housing. One single visit to the ER by itself without even being admitted, which otherwise is as much as $6,000 per day, is between $1,000 and $2,000 by itself and would constitute a substantial amount of the state contribution to a housing card alone. Just one day in the hospital, including ER and ED charges, would fully cover one or more years of housing subsidies, including the federal portion. Please accept this as written submission for the MAC, if not otherwise acceptable for this particular venue. Thank you, R. Drake Eubank, for your public testimony. And Sarah put in the chat, HCBS is home and community-based services. Is there any additional public testimony? Well, if there is not additional public testimony, shall we move to MAC discussion? So announcements, we did not have any comments on the marketing list. Should we vote to accept this as guidance for the OHA, or do we need to allow more time for comments? Would appreciate people's thoughts on whether or not we should vote today or leave more time. I know I personally did not have any additional comments to make. Did others have additional comments to make? Heather is shaking her head no. Kelly is also shaking her head.
I still believe that a sixth grade reading level is a bit high considering America's average reading level. I still think that's a little high.
Are there any comments on trying to change the reading level? I believe I apologize if I'm misremembering. Was this addressed earlier and that the standard level is sixth grade? I apologize. I'm not remembering quite clearly here. If somebody could jump in and help my memory of how we
Yes,
landed at sixth
so
grade.
yeah, the readability is grade 6 on the I think it's like Flesh Kincaid grade level, with a maximum score of 6.9, but the average reading level in America is not that high. So while it does seem low when you discuss it, it's actually not as accessible as one would believe.
I definitely remember
It's
that. Am I remembering that where did we come up with the sixth grade as a benchmark? That's what I'm not quite remembering.
It's in the OHA guidance. And so
Okay.
I guess, Shannon, I'm glad you brought that up because maybe for clarification, we shared that one and some other ones with OHA at the meeting, but I don't think we received feedback what they were doing with that feedback and that they received at that meeting. And so I'm comfortable reiterating the feedback that we gave them at the meeting again in a written form if folks want to, but I'm not sure. Again, I don't know. We didn't hear back from them about what they may or may not do with the feedback we gave them previously.
I think it could be
it looked
helpful to have feedback. I think Shannon makes a very salient, very important point here.
Yeah, so just a quick Google. Um, it's 54% of adults have literacy below a sixth grade level, and 20% are below fifth grade level.
I would be comfortable. I don't want to make unilateral decisions, of course, but of trying to receive a response before we vote on this. What are your thoughts about that, Shannon and other members of the committee? Heather gave a thumbs up. Kelly's nodding.
Yeah, I would feel more comfortable with that, at least getting a response, if not a change made.
Lisa's thumbs up. I think that's absolutely reasonable. And thank you, Shannon, for bringing this up again and helping us remember that we had not yet received a response. So thank you for highlighting that. It can be easy to give feedback and then sometimes let it slip through the cracks that we didn't actually get a response. So I think very good call out. So let's
And my
pause.
apologies for missing that. We'll follow up and get a response for January.
Thank you, Sarah. So we'll pause there. And okay, are there, just circling back to Lisa heading to sunnier directions, are there other expressions of gratitude or memories of Lisa's time on the MAC here?
I just want to say thank you to everyone, and thank you for all doing this work, and thank you for sticking in there when I'm running away.
Well, Lisa, it's been getting close to my end of term or closer. It's been a great pleasure to have you here when I started and to work with you for so many years. And just I just your contribution has been extremely meaningful and you've made a difference. So thank you so much for everything you've done. It's been a pleasure to know you.
Thank you for that, Heather. You were great on here as well. And if anybody would like to come and see palm trees and rainbows, come on out in Wales.
Your couch might be very full of rotating MAC members. Well, we wish you just the best of luck. And Sarah's speaking, but yes, thank you so much. Sarah, do you want to go ahead?
Oh, I was just gonna say that I also really appreciate Lisa's service both to the MAC and to the subcommittee. Lisa was a very reluctant to take on the chairing the subcommittee and did so because the need was was there, and I appreciated her stepping into that role, and she has done it beautifully, and I'm really going to miss her leadership. Oh, my friend, you are on mute.
Lisa, you're on mute.
I was going to say, sorry. Thank you, Sarah, for all your work. I just want to say that part of why I'm able to give such great updates is that Sarah has put the work and Tom have put the work in the background to write it all down. So it's not all my speaking ability. I am well equipped with the background. So thank you guys for all your work.
Humble as always. And we have comments from Laura saying thank you for all your service to this work, and from Carissa that worked with Lisa closely at the CCO, though not at the MAC. But Lisa, you've been integral for improving healthcare for Oregonians. You are an amazingly dedicated and compassionate person. Oregon will miss you. Yes, I think we are losing a powerful advocate and the whales are gaining a powerful advocate. And I do call that a definite plus that someone else is getting a great advocate. So I will, so thank you so much. If there are MAC members, is there any other additional discussion before we move to Plus Delta? So moving on to Plus Delta, any pluses? I know I loved the in-depth discussion around the HRS and HRSN. I feel like I need some really good, thank you, Jerry, we'll see you later. I feel like I need some flow sheets to understand what is covered. It's really challenging, but the depth of it is mind-boggling to me. But I really appreciate the in-depth dive today to help me realize that it is so much more complicated than I was aware of. Other pluses or deltas? Heather's got a thumbs up.
Just concurring with you that it's an amazing opportunity. And I think just giving us space to talk about outcomes and measurement so that we can really ensure, I know it's a big part of our work plan as the MAC to really support and ensure that we are tracking, monitoring, for providing feedback on getting closer and closer every day to our health equity goals in Oregon. And yeah, and this is such a great opportunity to do that. And I hope that we can continue to support that work and evaluating and moving us the needle to the goal. So I thought that was really a great conversation today.
I would also add a plus of that we had 3 members of the public providing public testimony today. It's not infrequent that we have 0 or 1. So I'm excited that we had a bit of an uptick today. The more public testimony that we can get and hearing from the public is really beneficial to our process. Other pluses or deltas? Okay, well, if it's silence, then I think maybe we can magically wrap up a little bit early, which is amazing. So our next meeting will be Wednesday, January 29th, 2025. Craziness, moving to 2025. And I'm just looking at my calendar. I don't have it written in there, Sarah. Where is it located? Do we know yet? In Salem. Okay.
Yeah.
Well, happy end of 2024 and all of the winter celebrations to everybody. Hope you are if you are crazy active ski jumpers or sit with your tea and book and cuddle in a wool blanket kind of person. I wish you well the end of this year and see you in I guess late January 2025. Take care, everyone.